Today we'll talk about a lot of different topics. I'm going to touch on radiation therapy as a treatment modality for cutaneous malignancies. I know Dr. Javadi is going to talk from a bit higher level about what these malignancies are, but I just want to go into some of the details about the radiation part of it. So what is radiation therapy? External beam radiation therapy acts through the interaction with photon radiation with individual cells, particularly cancer cells. So these X-rays enter the body, they interact with the water particles, and they create free radicals. Free radicals damage the DNA of the cancer cell, causes both double-strand and single-strand breaks in the DNA of the cancer cell, and causes them to hit the self-destruct button and then die off. It does cause some side effects, which is in relation to the effects of the radiation on the normal tissue. But cancer cells are very sensitive to radiation therapy. So this is a common treatment for skin cancer. I had to hit one more button to finish the sharing. So this illustrates the photons coming in and causing the damage to the DNA cells in the cancer cells. So when do we recommend radiation therapy for skin cancer? There's really two situations. One is for curative treatment. So this is a treatment that's given to cure the cancer. The other is a adjuvant treatment. So in addition to surgery or other types of systemic therapy. So those are really the two indications for radiation therapy. There's various ways to deliver the radiation therapy, and we'll talk about several of those today. So the two most common types, one is external beam radiation, so radiation from the outside. That can either be done with one of these superficial X-ray machines, or more commonly in use are linear accelerators. So these are available throughout the country. They use electricity to generate the radiation. So as opposed to previous cobalt-based units that actually had a radioactive source in the machine, these machines have no radiation at baseline. It requires you to turn the machine on, generate the electricity, which generates electrons, which generates the radiation. So it's less exposure to the patient to radiation, and it's less exposure to staff. And so these are what's commonly used to deliver radiation. On the bottom right panel, you can see these lead cutouts. So we can actually customize the treatment to the shape of whatever tumor we're treating. And this can either be done by putting these lead cutouts in the head of the machine, or we can actually put the lead cutout right on the patient's surface of their face or whatever area we're treating. And that allows us to get a really sharp dose of radiation to the area that we need to treat. The advantage of external beam radiation therapy is we can deliver high doses of radiation with very little toxicity to underlying tissue because we typically use electron therapy for skin cancer. So this is a very surface type treatment of radiation therapy that's given. The other type of radiation we can do is something called brachytherapy. So brachy is Greek for near, so near therapy. This is a type of radiation where we're actually putting a radioactive source near the patient. This is commonly used for various cancers, including GYN cancers, gynecologic cancers, but it also can be used for skin cancer. So we can deliver a curative dose of radiation therapy for very superficial lesions that can be done in as little as 6 to 10 treatments. Whereas our external beam treatments typically are longer. There's typically 20 to 30 treatments, daily treatments. So this treatment can be done for very early stage as an alternative to something like Mohs surgery. So here's a patient with a very early squamous cell carcinoma. You can see right here on the side of the nose, right here. And the patient didn't want to proceed with Mohs surgery, which would involve removing this with skin around it, and then the challenge of having to reconstruct this with a skin graft or something like that. The patient preferred to have definitive radiation therapy. You can see here on the right, this is the patient setup. So we put a mask on the patient to hold them still during treatment. We put some lead shields over their eyes as an extra precaution. And then this silver looking device is put on the patient's skin surface. That's hooked up via catheter to this machine here, which has a radioactive source. So this has an iridium-192 source that travels out along a cable after everybody leaves the room, very low exposure to the patient or staff, travels out the cable, and it stays in this device for just a couple of minutes and is able to deliver a curative dose of radiation to the patient. And you can see here on the bottom right, the patient had a great outcome with very good cosmetic outcome, whereas if they would have had surgery, it potentially could have had more scarring. So this is commonly used for particularly for patients that are over age 40 that have very small tumors and very good outcomes that we'll review in a second. So I'm not a surgeon, so I really can just talk about the radiation, but we typically favor radiation therapy over surgery in patients that are older, maybe they're too sick or weak for surgery, if they have bigger tumors, particularly in the central part of the face that could have a lot of disfigurement from surgery, if they're close or on the eyelids, nose, or lips, if they would have trouble removing it fully by surgery. Also, we can consider it for scalp, forehead, ear. And so these are common indications for radiation therapy. In patients that are younger, we really prefer surgery for these patients, particularly if there's previous radiation to that area, if they have inherent conditions that may predispose the patient to skin cancer. Radiation could contribute to increasing the risk of skin cancer in those patients. If they have some other contraindication for radiation therapy, typically these are very easy surgeries to do on limbs, elbows, things like that these are commonly done by our dermatologists. If they're really big tumors, then we worry that radiation may not be sufficient. And so in those situations, surgery plus radiation may be more effective. What are the outcomes from this? If we look at this large study, over 21,000 patients combined together, they found that conventional excision, this just means removing the tumor, had decent cosmesis, 81% had good cosmetic outcome, very low recurrence for really any of these. Mohs surgery, very good cosmesis, very low chance of the cancer coming back. When we do the external beam, the electron type treatment, that had not as good cosmetic, and that's because you can get some changes in the skin color, things like that can lead to a little bit worse cosmetic outcome, but the recurrence rates are still very low. And brachytherapy has very good cosmetic outcome and very low recurrences. So all of these are different modalities, and I encourage patients to talk to the different doctors to talk about the different options before jumping into a treatment. So just some case examples. Here's a patient with a squamous cell carcinoma, which is a common skin cancer in the ear. And you can see the lesion here on the left slide. This would be a very challenging surgery in that there's cartilage right below this. The patient may have to have some type of surgical reconstruction with plastic surgery. And so the patient opted for radiation therapy. Here's the patient several months later, and you can see the lesion responded really well, and the patient had a complete response to treatment. This next one is a patient. He was 75 years old, and he had this lesion in right below his eye. He met with a dermatologist, and actually he had really bad dementia, and his family complained that he started noticing that this was irritating the patient more, and he was fiddling with it, and they really wanted to take care of it. It was bleeding, and so we were able to treat him with just 10 treatments of external radiation, and this was 4 months later, and the family was thrilled. The patient no longer had pain and other effects from that tumor. Here's a patient with a basal cell carcinoma, so another type of slow-growing cancer that Dr. Javadi is going to talk more about in the lip, and it was pretty deep in the lip. In order to treat this with surgery, we would have to remove a good portion of the patient's lip, kind of in a pizza type triangle configuration, and then do some rearrangement of the patient's lip in order to in order for the patient to have a functional mouth where they could still eat and drink normally without having a smaller mouth that would prevent them from being able to eat something like a hamburger. And so this patient was referred to me to consider radiation therapy. We delivered 6.5 weeks of radiation with daily treatment. The patient had a great response and was able to continue with great cosmetic outcome, was able to continue to eat and drink normally. So what are the side effects of treatment? It really depends on the area that we're treating. And so when we treat patients with radiation, we always meet with them and talk about what these side effects are. They're broken up into either acute side effects that happen during treatment and then late side effects that happen after the treatment. So radiation is not one thing. It really depends what the patient's gonna experience. Today, I had a patient come in with a small skin cancer in the temple area that was treated with surgery, and now the patient needs radiation. That patient's going to have very little side effects. Whereas if we're treating a big area in the face and neck, the patient will have a lot more side effects with trouble eating and drinking and swallowing. But generally, when we're just treating the skin, the side effects are pretty limited. The most common things include redness of the skin, some peeling. You can see here this patient had on the last day of radiation, some redness and some peeling in the nose. And by 4 months, it was all resolved. You can lose some hair, that can be permanent. You can get some fatigue and some itchiness. We reviewed a little bit about the long-term cosmetic outcome, but generally it's pretty good. So here's some different situations, whether it's a scalp that we're treating, a nose, an ear, and a leg. And you can see overall, these patients have pretty good cosmetic outcome after radiation, and most patients are pretty pleased with how it looks after. We commonly use radiation therapy for squamous and basal cell carcinoma. There's also indications for radiation for melanoma. Dr. Gimbel is going to talk more about Merkel cell carcinoma, which is a rare skin cancer. And then we also treat some skin lymphomas. Some of these lymphomas we treat even with just 2 radiation treatments. So virtually no side effects. Patients do really well. Just an example of that's kind of fun. We have patients who have something called cutaneous T-cell lymphoma. So it's a disseminated lymphoma of the skin. And these patients, we have to treat all of their skin with radiation. And so these different diagrams here are the way that the patient stands. And so some wise person years ago figured out that if a patient stands in all of these 6 different positions, it will basically expose most of their, if not all of their skin to the radiation beam. And so the patient stands next to the machine, and then we deliver the dose. And so they make these different movements that almost looks like a dance. So kind of an interesting treatment. Radiation can be given for keloids. So keloids are an abnormal scar tissue that forms after some kind of trauma. And even just a handful of radiation treatments, very low dose, can be given after surgery to prevent this from growing back. So here's a patient with a large keloid after a ear piercing. That keloid was removed, then the patient had radiation, and it didn't grow back. So that's an effective treatment for these patients. So with that, I'd just like to thank you for the opportunity to discuss this today. I'm speaking from Phoenix. We also have 2 campuses up in Northern Colorado. So thank you for your time, and I'll turn it back over to the next speaker.